So we move on to our next speaker. I believe is Dr. George. He is a neurointerventionist from Radboud University's Medical Center from Netherlands. He will give a speech on his endovascular management experience in middle cerebral arteries aneurysm part 1. Okay, thank you. Please, Dr. George.
Thank you very much for having the opportunity to talk. Thank you, Luis Lopez-Ibor, for organizing, and I hope I have here spelled the Chinese characters correctly for the Chinese people that are watching, also the Spanish and Latin American people. Please forgive me if it's not correct. That's where my disclosure is. So we move on now to endovascular management of the MCA aneurysms. And well, to tell you, I am a hybrid neurosurgeon, so dual trained, doing both open and endovascular procedures. So I will start first a little bit talking also about open procedures and how we balance and how we decide to do either open or endovascular procedure. So I'm from Nijmegen. That's a nice city, old city in the Netherlands. For those people that don't know my country, it's in the northwest of Europe. And it's a tiny country, of course. So I completely agree with the previous speakers that the most appropriate device for the majority of MCA aneurysms still is absolutely a clip. And why is that? Because it's safe and it's effective. If you divide it on to different locations for treatment choice, the group from Johannes Nemiels Helsinki had by location made 4 groups of MCA aneurysms, and I think that's very helpful. And if you make the 2 distal groups in one group, that means the bifurcation and the distal MCA. In most of the cases, that is open surgery with clipping or other procedures. But the more proximal ones at the M1, it really depends upon the anatomy, and there's mostly the issue of the lenticular striate. So why the MCA bifurcation clipping? Because it's very safe, because they're rarely perforators, and it's more efficacious if compared to endovascular solutions, and that's because of the majority of those MCA bifurcation aneurysms has a wide neck. So actually that was already studied and proven in many studies, and you see it also here in a meta-analysis of more than of about 2,000 patients that were evaluated. So the high safety and efficacy of surgical clipping. So here at our institution, we try, of course, further to improve the clipping by means of safety and efficacy. And we think for vulnerable patients or complex patients, we think awake surgery is very helpful to get feedback how the patient is doing or how effective your clipping is. And beside that, we are very happy with the hybrid room, of course, to get feedback of with your intraoperative DSA. So this is a simple setup of in our hybrid room of a lady that had a severe cardiopulmonary disease. We discussed with the anesthesiology, and they said, well, we cannot put this lady under general anesthesia. So this is under local anesthesia. Here is one of the nursing staff is taking care of the lady. She is even not under conscious sedation, just local anesthesia. And she's doing also some regular neurologic checkups. And here, basically, you see there's an PCOM aneurysm with a severe atherosclerosis as well, and a tiny MCA. The MCA aneurysm was clipped. That was, as expected, uneventful, but we put a clip here on the PCOM, and she neurologically deteriorated, although there was a normal finding with the ICG, especially of the anterior choroid artery. So we did further dissections, etc. But when we put a clip, did repositioning, she still had repeatedly neurological deficits. So we finally end up coiling that aneurysm. So that's an example of that awake surgery can help you. We think that for MCA aneurysms, the age is not that important. Maybe for other locations that could be of importance, but here even old patients we think can be clipped. Here it is an MCA bifurcation aneurysm, typically a wide neck, maybe type 3 or 4. So you get immediately after clipplation your feedback that especially the 3D rotational angiography is helpful. This is a case also an unruptured aneurysm where clip repositioning was needed and where the DSA was very helpful because we put a clip and the basically the ICG and Doppler showed complete occlusion, but here you see some a tiny blush. So there's a need for a second clip. So that's what we did. We put here the second clip and then check again. And now it's okay. Those are severely atherosclerotic calcified bifurcation. That was probably the reason that the first clip was not enough. So dual trained hybrid neurosurgeons are rare in Europe. And so we wanted to inspire our colleagues and decided to collect our results and to publish that to inspire our colleagues to do it, become also like hybrid. So we collected 356 patient ruptured aneurysms and evaluated our results. And for this talk, interesting, what we found was one third of the MC aneurysms we treated by endovascular means. And so there was a recurrence rate of about 13%. So 1/3, we thought that was a little bit too high for MC aneurysm. So now we moved back or shifted back to more open surgery for those MCA aneurysms. Of course, it's not always perfect. This is a lady came in very bad condition in our hospital, WFNS5, and this is a fatal complication. Actually, it never occurred to me in all the like 30 years before, but you need to have every complication once. So she went for clipping. It's like a 2 centimeter aneurysm. We took out the hematoma, and there were a lot of issues with clip positioning, and I had a tear at the neck, lost the branch, many temporary clippings, and so basically we ended up said, well, we're a little bit concerned of her fate, so we took out the bone flap, put an EVD also for pressure monitoring. It looked pretty stable the first day, but the second day she started to increase with her ICP, and she had the CT scan complete, MCA infarction with hemorrhagic transformation. Took that out, debulked it, removed the necrotic tissue. ICP was well then next days, but she didn't improve in her neurologic condition. So that's after 2 weeks, complete MCA infarction. And so we withdrew the therapy and she passed away. So, but overall, I think our experience with the clipping of the MCA aneurysm, whatever location of the MCA, it's safe and efficacious. It's feasible in old patients and in complex patients or vulnerable patients, consider awake surgery. And we think the hybrid room and intraoperative DSA is very, very helpful. Although neurologic deficits are very rare, a substantial amount of patients do complain of postoperative headaches or fatigue. So, and they say that's a huge difference if they have also been treated endovascular with an endovascular technique. So we move forward now to endovascular strategy, and this is a case similar to what Professor Bingshu showed previously, and that shows that it's very nice to be a hybrid or a dual-trained neurosurgeon. This is a complex MCA aneurysm, partly thrombosed of the inferior trunk of the M2. Also. And so here, this is not a case for a standard technique. So here the decision was to occlude this branch, the diseased branch, and to do a low flow STA MCA bypass. So with the help of navigation techniques, we choose the right craniotomy site, go in with a microcatheter and do a selective injection to the diseased branch to look to find the recipient artery, which you can see here now. do the bypass, and then have occlude the disease branch, occlude the aneurysm. And so we end up with a nice remodeling of the left MCA territory. So endovascular options, next part of my presentation. So basically the last 10 years, especially, there are so many new devices, all kind of devices, that it's very difficult to choose, and especially also in Europe, it's easy to get CE approval. So you have so many devices, it's very difficult to choose which one would be the best. And so there are so many options. But of course, so you have here the balloon, then the stents, then the intersaccular devices, web contour, P-conus, pulse rider, flow-diverters, and the flow-diverter-like implant called Eclipse. So I like the last 10 years, and definitely 10 years ago, we were very inspired by all those promising devices, and we wanted to use them because, well, we thought probably that are good solutions for any aneurysm, because it's not very invasive therapy. So to start, I will go through the different endovascular options we have, and the experience at our institution. So bare coiling for an MC aneurysm is definitely possible, but you need a favorable dome neck ratio, or at least more than 2. You can do it if there's an open neurosurgical contraindication, or if the patient refuses open neurosurgery, and this is not rare in our culture. The problem is that the favorable dome neck ratio is very rare. It's about only 10% of the cases you will see that. But neurosurgical contraindications, for example, here in an acute case, very old patient with WFNS4. So here we thought it might be better to choose a less invasive short procedure for this MCA aneurysm. Just put a couple of coils in, and that is for this lady, probably the best, and see if she recovers. Here, probably we made, I think, hindsight, not a very wise decision. This is a young male, multiple aneurysms, but a ruptured left MCA aneurysm. We thought, well, the dome neck ratio is favorable, and neck is not wide, but well, this is definitely also a surgical case, probably. But so we called that. It looked pretty okay, but the first, second, and third year post-op looked good in the MR, but fourth year there was a recurrence, and now it's a wide neck. And what Professor Henry showed, it's not always easy. We did that also like 10, 15, 20 years ago, do clipping after a previous coiling, but when the clips are very close to the neck, and there's also atherosclerosis, that is pretty difficult and tricky to get thromboembolic complications, etc. So we don't like to do it anymore. So here, and now there are better stents as compared to 15 years ago and 10 years ago. So we decided here to put, for the recurrent aneurysm, put an Atlas stent. So now it's easier to put stents and to coil it. So this is the final result. We see how it looks in the next year. This is a similar problem of a patient that had a ruptured MCA in France, had a bare coiling in France, and then rebled 6 months later and was retreated with a bare coiling. She moved to the Netherlands. Now she came to us, and here you see again, you have a problem now with the coils, and it's a very wide neck of about 7 millimeter. And the coils are unfortunately very close to the neck at this area. So we think clipping could become very complex. So because it's a very wide neck, we think stent-assisted coiling here is not very helpful. I will explain later why we think it's not very helpful. So we just did a bare coiling. Here the neck is more than 7 millimeters, and well, it's not very perfect. We're pretty conservative, and as expected, yet recurrency 2 years later. So that was this year, 4 years after the first coiling. She's doing fine, but because of the recurrency, we said we need to coil again. So now we're a little bit more aggressive as compared to the previous coiling. But the problem with stent-assisted coiling, as we see it at our institution, we studied our recent stent-assisted coilings, and so now it's easier to use stents because, for example, the Atlas stent, it comes in an 017 catheter, which is easy to navigate, and it are so easy to use stents now. But still, the problem is that that's what we found in our series, that as soon as the neck is more than 4 millimeter, you find only in 1/3 of the cases a complete occlusion at follow-up. And these are results scored by an independent reviewer. So maybe web is the solution. Of course, like many others, we thought, well, web, we are inspired by the web because it's also, again, it's easy to use. So here, this patient, ruptured MCA, 8 millimeters dome, 4 millimeter neck. So we put an 8.5 web, and actually it looks beautiful. So we get a nice thrombosis, and here the positioning of the web, it seems to fit pretty nice. So we are very happy. At 1 year follow-up, it looked nice, but at 2 year follow-up, you get collapse of the web. You get like a new aneurysm. So it needs to be retreated because he has had a history of subarachnoid hemorrhage. And so we advised her to do surgical clipping because now it's that there's enough space below the web, but she didn't want to be clipped. So we did here Y stenting and coiling, and actually that looked pretty nice. At 1 year follow-up, it still looks okay. So we have to see how it looks with further follow-up. So this was pretty effective now. Pulse rider, limited experience, but he has an MCA case with 2 lobes, and you put the pulse rider, and through the pulse rider you can coil, and here we get a good complete occlusion, which at follow-up stayed also as a Raymond 1. Unfortunately, the patient had a thrombobolic complication, but the patient recovered from that thrombobolic complication. So at our institution for MCA aneurysms, we have no experience with the other devices. So in summary, the results of stent-assisted coiling in the literature, there is a recent systematic review performed, and their conclusion is, so they see a long-term complete or near complete occlusion rate of a little bit more than 70%. That is maybe okay, but in aneurysms where there is also a surgical option, I think that's not enough, and that's also their conclusion. It's not ideal. That's more than 2,000 patients that were reviewed. Another thing is, most of the studies in this systematic review are retrospective studies with operator-assessed data. So that makes a difference. That was also documented in other reports, but also here specifically for wide-necked bifurcation aneurysms. There's a difference between operator-assessed or self-assessed data and core lab results. And you see here, that's a difference in about 10% in the efficacy, so complete occlusion from operator-assessed studies and independent reviewer. So this is like trials. So, of course, the recent devices have been, I think, probably better studied. As absolutely, the web has the results have been documented in many studies like the webcast, but still, this is not only MCA, of course, but still you face the problem that you have like 20% or completely occluded aneurysms. So I think still, if you look for MCA treatments, there is a problem for these endovascular solutions of the incomplete occlusions and the recurrency rate and retreatment rates. So we move forward and say, maybe flow diverters, would that be a solution for MCA aneurysms? And I am a big fan of flow diversion, and we were also involved in some development of flow diversion, so we have been using it since a very long time. So, so to conclude, first, what we have found at our institution, that MCA bifurcation aneurysms, flow diversion is not very effective. And one aneurysms that can be more complex or difficult. So that might be a good indication for selected cases. And interestingly, why a aneurysm bifurcation aneurysm would be not so very successful for flow diversion. Actually, this was well studied by this group from France. It was recently published. So basically what they found, if you have an asymmetric, this was a CFD study, if you have an asymmetric bifurcation, that's more like a situation in an M1, there's a high impact on hemodynamic flow by the flow diverter. In a symmetric bifurcation, that's less. That might explain the difference in results. So here this is a small series from our center, flow diverter results, and we found it's not a large group, but we found that in bifurcation only 50% occlusion by flow diversion. And actually the same results were published by a Turkish group, satisfactory occlusion rate in bifurcation aneurysms. So M1 probably could be interesting. This is a young lady with multiple aneurysms, at a rupture of an ACOM that was coiled. And so this was like 8 years ago, and I wanted to clip this aneurysm. So we opened up and this was completely calcified and all the clips slipped, and said, I'm not so happy with this. And so we shifted towards endovascular therapy, and we put here a flow diverter. And at 6 months, you see a very nice occlusion of these aneurysms. And it looks a little bit weird here. It is cortical branch. And actually, if you look at the distal part here, this is at or before flow implantation. You have here this cortical area, which has changed afterwards. So it's definitely a flow redistribution. So there is a little bit less flow in that artery, but the lady was doing fine. She was neurologic intact. And you see here, she has made her own bypass through pile collaterals from the posterior circulation. A short note on MCA aneurysms, additional MCA aneurysms. One of our fellows did a very nice research on additional aneurysms in patients with the subarachnoid hemorrhage, and especially the MCA aneurysms have a way higher risk as expected according to FACES score. It's about more than 3% per year. So that is, I think, a pretty good indication for prophylactic surgery in case of multiple aneurysms and previous subarachnoid hemorrhage. This lady also, after subarachnoid hemorrhage of a PCOM aneurysm, inferior M1 aneurysm, she wanted to be treated as a flow diverter. She didn't want to have clipping. So that's what she got. Difficult to see maybe, but here's a 2 millimeter flow diverter. After 6 months, you see it's a little bit regression, but not occluded, but after 4 years. So it took quite a while. And there you see now the aneurysm is more or less completely occluded. She had a mirror aneurysm on the right, MCA, and also put a flow diverter here at the M1 trajectory. And after 1 year, that was occluded. This is a more difficult aneurysm. I think the typically superior pointing aneurysm with close M1 aneurysm with close contact to the striates. Probably not a good surgical case because you can damage the striates. For clipping, it's very tiny and the angle is sharp. So we said, well, now with the modern flow diverters that are so easy to use, we used the Silk Baby Vista of 2.25 millimeters. And so we put it here. It went very well, but she woke up with a slight left-sided hemiparesis. Did a CTA. I was concerned of occlusion of the covered branch because you see here this branch was covered by the flow diverter, but there was a thromboembolic complication. At least it was the image of thromboembolic complication, and so there was a defect in the CTP, but she made luckily a full recovery. So acute cases, we did also a couple of acute cases when there were no other solutions. This is a very difficult to treat M1 aneurysm, I think, with also the lenticular striates involved. And this is, of course, could be a possible bypass candidate, but we decided for an endovascular bypass, which basically a flow diverter is. But we also wanted to coil that aneurysm. So we do a jailing technique. We put a microcatheter here in the aneurysm. Here is the wire for the flow diverter. This was the over-the-wire flow diverter, which now does not exist more, but the old generation flow diverter. We do a very long one, deployed it, and then did kind of a loose coiling. We didn't want to do a high packing because we're concerned about the striates, but we got a nice remodeling, and basically the striates were patent. And he had a tiny lacunar infarction, but recovered pretty good from that. And this is the 6-month follow-up. So we're a little bit optimistic about the acute treatment with flow diverters on a ruptured aneurysm. We thought, well, that worked pretty nice, but we did a research with more European centers, also one US center from Dr. Waklow. I was a little bit shocked of the results we saw in this, if we collected the data, 44 patients. So we had 27% procedure-related permanent neurologic deficits, of which 11% rebleeds. So this is not the first choice treatment, only when there are no other options. Here, this is a fatal case of flow diverter and in multiple aneurysms, family history of aneurysm, symptomatic, giant, partly thrombosed, right ICA aneurysm with a MCA aneurysm. So the plan was here to coil that MCA aneurysm in one session, put a flow diverter. But for some reason, we were not able to access with a microcatheter the MCA aneurysm, so we decided to clip that later and to put only flow diverter. Then there were issues with the delivery wire of the flow diverter system. It constantly went into the MCA aneurysm, so we had to take the flow diverter out and had to go very distal into that branch to deliver the flow diverter. So that's what we did. We ended in the M1. We did a run afterwards and we had a wire perforation. So we had to do a balloon occlusion, reverse the heparin and give platelets. We're not very happy, of course. After 10 minutes balloon inflation, it seemed to be okay, but we waited a while and we got reopening of the site, so we had to occlude it with coils. Express CT looked not too bad, so we said, well, maybe this is not a big problem, but then I think we maybe made a mistake. We should put probably an ICP monitoring and monitor the patient, but so we didn't do that. So 4 hours post-op, she got a dilated pupil and the CT shows further bleeding. So we took her to the OR, decompressed it, but didn't help a lot for her. She passed away. Like I said in the beginning of the flow diverter, this is like a case 8 years ago. You were very optimistic that it was the perfect solution for maybe all the aneurysms. So this is a incidental finding. The patient didn't want to be clipped. So we said, well, let's put, the plan was to put a flow diverter here. So we did an exchange maneuver first with the Prowler 10, we went into the upper branch and then exchange for the flow delivery system of the flow diverter and put here the flow diverter. We changed the anatomy, of course, but the patient did well and this was a complete occlusion. There's a rare aneurysm just distal from the bifurcation. So it is like a side wall. So flow diverter and worked for this case. But the real bifurcation aneurysms, we were less successful. This is a lady that had a rupture of this larger aneurysm that was coiled, but she had two tiny aneurysms, and one of those was on the bifurcation. So we put a flow diverter here in expectation of being successful, but that actually didn't work that well. Maybe we skip this for time reasons. So basically, in summary, and also what here was found in a systematic review meta-analysis, so you find a little bit higher occlusion rates as compared to stent-assisted coiling with flow diverters. It's approaching 80%, but you have a 10% complication rate in this systematic review. So again, use it for selected cases and definitely not, I think, for an MCA bifurcation aneurysm. So in conclusion, the endovascular treatment of MCA aneurysms, especially in Europe, we have many devices apart from just bare coiling. And so it's difficult to choose. And I think approval in Europe has been too easy. That's not possible anymore now. There is a more strict rules to enter the market to get CE approval. But the devices, I think, have now, until now, most of them have a low evidence, especially of long-term efficacy. So we need data to see how it works. And of course, we have data, long-term efficacy data for clipping. But of course, there are complex cases, and there is definitely an indication for selected cases. And there, I think flow diversion seems to have the highest aneurysm occlusion rates. So thank you so much for your attention. That was my presentation.
Thank you very much, Dr. Josh. It was really presents both the surgery and the endovascular case, and a lot of techniques that you present. So next is should be questions. Is there any questions from the panelists?
Okay, thank you, Professor Jost. You skipped the result for the eclipse.
Yeah.
I want to know it.
I can go back. Of course, I will. Because I thought maybe it was a little bit too long time, but.
No, we have lots of time. No problem.
Yeah.
Let me try to do it again. Screen share. No, the reason I skipped because here we go. So because we cannot use it yet for MCA bifurcations, but
okay.
Thank you for your question, because basically it is a flow diverter technique, but it's not a tubular. It's not a tubular device, so it's more like a shield or a plate with feathers. But this is the aneurysm neck cover that you can see here, and this has a 30% metal percentage, so it's similar to flow diverter, but it's not abraded. So this is the aneurysm. This is the anchor part that anchors the device in the side branch. So basically, it works like a stent now. This is the new generation. So you put your catheter here in one of the side branches. You can choose. This is a basilar tip now. So the device is now comes in a 027 catheter. So I think it's a little bit too big for a MCA aneurysm. So for basilar, it works well. So company is now working on an 021 catheter, which probably is possible for a MCA, depending on the anatomy. So basically here, you put here the device like a normal stent, comes to the catheter, so you unsheath it. So, and then it's mounted on a delivery wire. It's like almost like an acai wire, which you can torque. So then you push it with that wire into the other branch with the help of the catheter. So typically like a 45 shaped catheter will be helpful. And then you push it into the other branch and drag it. So in order to have a complete neck coverage. So the advantage is, of course, you have your flow diverter properties only at the neck of the aneurysm. And so actually we investigated that the results of 24, so it's not widely used because the previous generation was a little bit more difficult to use probably. So we had 24 patients in the European Center as well as in Canada. And I think it's promising because we had a very nice high occlusion rate of 95%, MRS, so Raymond Roy score 1 and 2. So that's about the eclipse, but again, it's not for MCAs.
So I noticed that one patient died due to guide wire perforation.
Exactly.
Yeah.
Yeah. So that's the old system was an over the wire system, and like in older stents, you can have this distal wire perforation that we. So the newer system is not an over the wire system. It's like what you saw in the video. And so this was very sad, of course. It was a very distal perforation, and I was there. It was in the UK, and we missed it. You clearly, hindsight, could see it in the angio. It was a carotid terminus and very distal at the pericallosal artery. There was a perforation. Yeah.
So do you need to deploy it to use some electronic things?
Yes, exactly. So it's electrolytic deployment. Exactly. Yes.
Okay.
Like a coil.
Mm-hmm. Okay, thank you.
Yeah.
Just thank you very much for your presentation. You are really, I agree with you with your comments to the new crazy device to endovascular and the critical point of view of the surgery of vascular, what is better, what is not better. I agree with you with your comments, but one question. In Holland, you are experienced and you are the first center or the good center to the bypass with Professor Tulleken with ELANA system. What do you think? Where is your opinion with the effectivity of the bypass with ELANA or not ELANA system? Where is your control or your opinion with the patient come to Holland and treated with bypass? And this is the fantastic result, or also have a critical point of view in your opinion? Thank you.
Yeah, so to be honest, we of course, don't use the ELANA ourselves because Tulleken, although he's retired, but his center and now Professor Bart van der Zwan is doing this technique. So in the early years, we did refer patients to Utrecht because it's 100 kilometers from us to do ELANA bypass. But actually, in Utrecht themselves, they do only few ELANA bypass. So it's really decreased, and the technique is very beautiful. But it's so they do mostly like the techniques like like Professor Bingshu described, and so it's maybe a little bit sad because it's a beautiful technique. It's a great idea of Professor Tulleken, but even at their center, as far as I know, they don't do it. They do it only a couple of cases per year, and most of them as non-ELANA. So they have very nice, still they are working on it. So they have the CELANA, the sutureless ELANA technique. And so, so they are still working on further improvement.
May I comment on that?
Yeah.
We were doing in Helsinki, ELANA. We learned from Professor Tulleken. We made maybe 35, 36 cases. We gave up because it was too complicated for us. I think only Professor Tulleken could do it, so, because it was so difficult to get the flap. The idea is wonderful, but in practice,
Yeah.
The same happened also in Berlin and in many other hands. So it was not widespread. And now I hear that it's also going down in Utrecht. So
yeah, exactly. That's true. Yeah.
Yeah, it is maybe too difficult technique. Like Subin said, that it should be simple technique. This one we can manage. One thing about the comparing endovascular and open microsurgeries is the economy. The poor people cannot have endovascular treatment around the world. This is one of the drawbacks. It is extremely expensive as compared to open microsurgery. This is everywhere in the world where I have been working, and I see that, for example, in Nepal, people didn't have even money for a clip, not to speak about endovascular surgery. In China also, who has open microsurgery? Poor people without insurance. They have clipping endovascular surgeries reserved to those who are more wealthy. So we are speaking about the first world treatment here.
I agree. Yeah.
Okay, this is my comment. Yeah, thank you.
Another comment, just in Netherlands, you are another neurointerventional, have a lot of experience with web devices in middle cerebral artery. And he come one time in Madrid. I very surprised because never talk with the recanalization of this device. What is your opinion with endosaccular device and the rate of recanalization?
I think it's a huge problem. I think it's a huge problem. So we have limited experience with the web because we have our doubts about the efficacy, especially in the MCA, because there are alternative treatments. And so, like I showed you the case, that's why I wanted to show you in the beginning. But now we have changed. We've seen many devices, and the efficacy is doubtful, and especially long-term efficacy. For the web, typically, we have many cases that after 1 year, it looks perfect, and the problems arise after 2 years. And so I think we have to wait a little bit, but we've seen that a couple of times, and for me, now it's clear. We only do it in selected cases when there is no other option. For example, if you have the ruptured wide-necked basilar tip, you can put, of course, coils in, but you will sure there will be a recurrency, and recurrency probably we would treat, of course, with eclipse. But in such cases, you can do not an eclipse in the acute stage, but you can do a web for a ruptured basilar wide-necked basilar tip. And so there are other cases that it's, especially in the acute stage, that would be helpful. But I'm really concerned, and I think it's important to see long-term follow-up, because that's what we in our series see is a problem. Good question. Thank you.
So, is there another questions? If there's
I
no...
just want to comment that the follow-up is the key to see something. You have to follow up the cases many years, and this is lacking in most big countries. And you should not publish your cases immediately in Facebook or LinkedIn or WeChat, whatever. This is nonsense. You should have follow-up for the cases to show that you are doing well. This is only advertisement and not the reality. And this is not good for the patients and the medical society community. But thank you for your critical, good lecture. It was very nice, Jost. Thank you.
Thank you.